We want to also let you know that we are recording today's session, and we'll make the recording available to everybody in about a week. Within a week, you will be notified via email how to access that recording. And yeah, so please chat with us, be on camera, hang out. Next slide, please. As a reminder for everybody, CTRC does not provide any legal advice, and we have no relevant financial interest or arrangement with any organizations to discuss today or commercial products mentioned. CTRC is grant funded through HRSA's Office for the Advancement of Telehealth. And that's CTRC. We are really thrilled today to bring a wonderful presenter, Monica. Monica is a partner and healthcare and life sciences lawyer with Foley and Lardner. She focuses her practice solely in representing healthcare providers, pharmaceutical and medical device companies in the area of healthcare transactions, clinical research, supply chain, and food and drug law. Monica is co-chair of the firm's life science industries team, and she is also vice chair of the firm's healthcare industry team. And we love Monica. We've had her a few times. So thank you, Monica, for being here today, and I'll hand it over to you.
No, thank you. It's a pleasure to be here, and thank you for having me. I appreciate it. I think this presentation is going to be very timely. There's a lot that we can speak regarding in terms of what is happening in the world of telemedicine, telehealth, the regulation, pre, post COVID waivers. And we can also touch upon the DEA new rules as well. So sorry, as I'm trying to advance the slides here. So similar to what has Lynn said, this presentation, while I'm an attorney, is not legal advice on any specific facts or circumstances. The contents are intended for general information only. So again, happy to answer any questions following the presentation. If there's anything specific you'd like to ask, happy to do that. So really quickly, what we're going to focus on today is telemedicine pre and post COVID. So we're going to start with looking at some of the the national trends with some California trends as well, issues addressing licensure and practice standards, looking at specific impact on reimbursement, specifically Medicare, HIPAA, DEA, and prescribing. We know the proposed rules regarding controlled substance prescribing just came out, and we'll touch upon those. I want to look at and focus briefly on the OIG's focus on fraud and abuse areas, where we see and where we predict they are going to look at enforcement. And then if we have time, touch upon the continued expansion of the use of telemedicine to conduct virtual clinical trials. Do forgive me in advance, the number of slides that I have here is very ambitious, and I acknowledge that. So I'm going to try and go through them quickly and touch upon as many areas as we can. I really was hoping that this would be a high-level overview of some of where we're at, some of the changes, and how to plan for the future, with the understanding that I'm happy to provide additional information post-session. So really quickly, as I'm sure everybody is very aware, the regulation of telemedicine, there's a number of overlapping regulatory considerations and bodies. There's regulations by states, there's regulations that are imposed by payers and by Medicare. So professionals, hospitals, physician groups, et cetera, really they're regulated at the state level, and they're regulated through licensure, requirements on practice standards, et cetera, and we'll get into some of that. Really, Medicare doesn't actually regulate the provision of care by telemedicine per se. However, it has conditions of participation which greatly will govern and regulate, if you will, providers who are engaging in services via telemedicine that are also Medicare participants. In a similar vein, state Medicaid plans, Medicare Advantage plans, and private payers also have conditions for payment, which serve in essence to regulate telemedicine. Again, licensure is very much state controlled, practice standards are state controlled, and prescribing is state controlled, but it's also federal. There's federal constraints too when you're looking at prescriptions via controlled substances. So those are the basics. Those are the high levels. So where are we at right now with these specific regulations, and where were we during the, where were we at previously, where were we at now during the pandemic, and where are we going after the pandemic? The first topic really that it has a major focus is licensure. Now, this is where we're at now. So essentially regarding, the medical practice, physicians, practitioners, clinicians are generally regulated in terms of licensure in the state in which they're at. The vast majority of states have a rule that the law governs as a state where the patient is located. So if you have a provider in California that is providing services to a patient that is in Illinois, say, or Florida, anywhere, that physician then would need to be licensed, in the state in which this patient is located. So in Illinois or in Florida, in those examples. Now, some states expressly address this in law or in their guidance documents. Other states address this in an indirect manner by addressing licensure in terms of the practice of medicine, and other states are silent on this. Now, there have been, and there were several waivers to these requirements that were put in place by states in response to the pandemic. Many states had waivers which allowed the physicians to provide services regardless whether or not the physician was licensed. Some states had a special registration exception where the physician could have a limited license to provide services during the pandemic in that state if they apply. There are multiple waivers. Unfortunately, right now, the waivers are gone with respect to licensure. Many of the states retracted their waivers or let them expire earlier on, despite the fact that the pandemic and the public health emergency kept getting extended by the government. So where this leaves us right now is for practitioners, health systems engaging in telemedicine. When you are a practitioner, in California, and you want to provide services for patients in states outside of California, you're going to still need to have a license in that state. This does create hurdles, and we recognize that. State, public officials are recognizing this. It's becoming, seen as a hindrance really at a national level. So this really can disincentivize providers from providing services via telemedicine. So we're aware of various, agencies and bodies that are putting forth, public comments and seeking changes in legislation to try and address this so that there could be some national standards for licensure. I think we're very far from that, to be quite honest. Right now in California, your rule is that any physician using telehealth technology to provide care for patients who are located in California must be licensed in California. So if you are a physician licensed in California, you're providing services for California patients, even through telemedicine technology, that's fine, you're licensed. If you are looking to if you're a health system, you're looking to contract with a national provider group for the provision of care for your patients via telemedicine, those providers are also going to need to have a California license. Now, I'm sure as you know, there's various exceptions to the licensure rules, such as consultation exceptions, bordering state exceptions, special license or registration exceptions. That's the abbreviated license or registration for telemedicine only care that I mentioned. A lot of states during the pandemic increased the ability to use that. When these exceptions are all still in place, if your state has these exceptions and can be used to obtain licensure. This is just a snapshot on an analysis that you could go through when you're looking at to see if a peer-to-peer consultation exception applies to licensure. So for example, in Delaware, there's a limit on the number of times that you can actually use this exception. It's limited to 12 times per year. And it's required that the consultation can only be physician to physician. It's not allowed to be physician with any other type of licensed professional for it to actually be applicable. So when you're going through and looking at, are there any exceptions, you really need to look at for your state and for the state in which the other provider is in, are there any exceptions apply? So for you, example, in California, you do have a peer-to-peer consultation exception that is valid. And essentially, what your exception says is there's, when a practitioner is located outside of the state of California, that practitioner does not actually need to be licensed in California when an actual consultation or when invited as a guest, the CMA or the California Podiatric Medical Association to provide consultation. So you do have a limited consultation exception. Now, there's also, I'm sure as you know, the interstate licensure compacts. There is a nurse licensure compact, there's a medical licensure compact. And what the compact does is it's an expedited way for providers, physicians to become licensed in bordering states or in any state that participates in the compact. So it's really an abbreviated mechanism where if you're licensed in a state that's participating in the compact, you can go through an abbreviated licensure process. And once you complete that, you are then able to be licensed in any of the other states that are participating in the compact. So it's a quick way to obtain some licensure. Unfortunately, California is not currently a participant in the compact, at least in the medical licensure compact, but there's a hope that maybe one day you will be able to. So telemedicine state practice standards, as I mentioned, the regulation of telemedicine is predominantly at a state level. And this is a snapshot of the various ways that states regulate the conduct of telemedicine, the conduct of provision care via telemedicine. So, for example, there are requirements as to when you can use telemedicine to create a new patient relationship versus when you can use telemedicine for services with a patient with whom you have an existing relationship. There's requirements for in-person examinations to create an existing patient, or to create a new patient relationship. There's special informed consent requirements. There's requirements regarding, what can be an originating site. Again, remote prescribing restrictions. So there were, again, during the pandemic, a lot of waivers to the requirements, to the state practice standard requirements. Again, most of those have gone away. So this is, again, a snapshot of an example of what you would need to look at when you're determining if you're going to actually provide services via telemedicine. What do you need to do to establish a physician-patient relationship with a new patient? So, for example, in Delaware, you could use, audio-visual, interactive types of modalities to provide services to establish a new patient relationship, but you couldn't use asynchronous technology or store and forward technology. Then again, after you created that new physician-patient relationship in Delaware, you could use any of those modalities. And then there's requirements for what type of modality you could use when actually prescribing non-controlled substances. So again, what you need to consider when you're looking, at establishing and providing services via telemedicine is what is required in the state you're located in, and the state in which the patient is. For California specifically, a few examples is, I've formed this in the form of a question and answer. Could a California physician perform or establish a patient relationship using telemedicine technology without an in-person exam? Because I think it's mentioned a few states require, if you're establishing a new patient relationship, in order to do that, you have to see them in person. Now, California says that you can establish a new patient relationship without an in-person exam. That is allowed. So essentially, you can establish the relationship using telemedicine without an in-person exam. So you have more flexibilities than some other states do. And then what type of modality is required to establish this? California is silent. You do not actually have a specific statute that says, you have to use, interactive audio visual. You don't have a statute that says you cannot use asynchronous or store and forward. Now, what we normally see is when any state law is silent on a particular standard to establish a relationship or what type of technology you need to use, really the best practice is to make sure that you're using the appropriate modality, the appropriate technology to really be able to provide care for that patient. It needs to be in the discretion of the physician. What is appropriate within the scope of that physician's license, and what is an appropriate clinical standard? Is the care that you're going to provide to the patient, is it suitable based on that care to establish that relationship using telemedicine? Or is it of such a nature or specialty that the use of a telemedicine technology really would not apply? So those are things that you would need to think about. And I use California examples, but I also provide the examples of other states due to the nature of the care via telemedicine, right? So when you're a California physician, if you're providing care via telemedicine for a patient in a separate state, bordering state, what have you, you need to be aware of those requirements. So reimbursement, Medicare. This is a large driver, of course, of telemedicine and the use of telemedicine, because again, while Medicare doesn't per se regulate telemedicine, to receive reimbursement for services provided for Medicare beneficiaries, you have to meet the Medicare requirements. And so that's really how they regulate it. So pre-COVID, and this is relevant because you need to take this into consideration post-COVID. Pre-COVID, in order to receive reimbursement for the provision of telemedicine services, you had to meet these criteria. So the patient had to be in a qualifying rural area. They needed to be at a qualifying facility, as you know, also called originating site. The qualifying facilities included, hospitals, nursing homes, et cetera. Service had to be provided by an eligible professional, a distant site practitioner, i.e. physicians, physician assistants, nurse practitioners, et cetera. The technology, the modality needed to be real-time audiovisual. It had to be interactive. So again, no asynchronous, no store and forward. And it has to be, the service had to be among the list of codes covered by Medicare. Now, thankfully, during the pandemic, Medicare had a number of telehealth waivers. They were broad and they were very, very helpful. This is a snapshot of some of them. For example, and we'll go into a little bit more detail. There was a removal of certain geographic and facility requirements. There was extensions on what type of technology, what type of modality you could use. Additional CPT codes were provided. It expanded the type of professionals who could provide telehealth services, and they addressed direct supervision as well. So specifically, I want to focus on some of these because it's important to know what is going to be continued for how long and which of these are going to go away and what are permanent. Because understanding what is going to be extended and for how long, and then what eventually is going to go away, needs to be taken into consideration as providers look to revamp their practices, their policies, and address how they're going to provide these services going forward. So for Medicare, during requirements for licensure, now during the pandemic, the Medicare waived their licensure requirements and said they, essentially said they waived the requirement that the physician needed to be licensed in the state where they provided services, subject to the following conditions. They had to be enrolled in Medicare. They had to possess a valid license in the state in which they were enrolled. They had to provide services, regardless of whether in person or telehealth, in the state in which the emergency was occurring. Of course, it was throughout the United States, so that made it easy. And they couldn't have been excluded from participation. They also relaxed the enforcement requirement that the patient had to have had a prior patient relationship with the physician prior to the performance of the services. So they also essentially, looked at payment parity. So prior to the emergency, any telehealth services were reimbursed at a lower rate than in-person services. During the emergency, Medicare changed that. They waived it so that reimbursement was at the same rate. So if you were providing services via telemedicine, you would have received the same reimbursement as had you provided an in-person exam. Again, unfortunately, that's going to be going away. That's not going to remain. The OIG relaxed enforcement against providers who decided to waive or to reduce cost sharing amounts for telehealth visits that were paid by federal healthcare programs. Again, they wanted to make sure they were encouraging, patients to go and receive proper care. There was also a waiver of the limitations on the frequency at which certain services could be provided via telehealth. So there was no frequency limit on subsequent inpatient visits or subsequent skilled nursing visits or on critical care consults. Let's see, they waived modality requirements. Again, I mentioned before that it was only, interactive audio video. You couldn't have any asynchronous use. However, during the pandemic, they waived the requirement of audiovisual functionality and the prohibition of use of telephones for certain services. You could actually use telephones to provide some care and consultation. And then there was a lot of relaxation, and we'll see that some of these are going to continue for the provision of certain substance abuse disorder treatments and also mental health. Specifically during the PHE, opiate treatment programs could conduct therapy and counseling through audio-only sessions, through telephone conversations. So that's a snapshot of some of the reimbursement waivers that were in place during the pandemic. Now, the public health emergency is scheduled to end in May. So we need to take care, and providers need to plan for how they are going to transition back to their practices that were in place pre-public health emergency for those waivers that are going to be going away. Now, the good news is that the Consolidated Appropriations Act extended some of the waivers that are in place, and there's some of the waivers that actually are going to be permanent, and we'll touch upon those. So the CAA extended the following telehealth flexibilities until December of 2024. So you have over a year to continue to use these flexibilities unless they are continued to be extended. But best practices, and what we see a lot of providers doing, while they have this extension now until the end of 2024, they're starting to plan for and put processes in place to, again, make sure they're going back to understand what processes they need to have so that when the waivers are gone, the extensions, what they can do to provide these services and how they can receive reimbursement for them. So in terms of the extended flexibilities, the extended waivers, healthcare providers eligible to bill Medicare, if you're enrolled, can bill for telehealth services regardless of where the patient or the provider is located. So this is a phenomenal flexibility. And it's a hope that even post December 31st, 2024, this will continue to be expanded and extended. The hope is that it will become permanent, because this allows the provider to provide services to the patient, to somebody like me when I'm in my home. Recall that when this goes away, to receive reimbursement from Medicare for certain telehealth services, the patient, I would actually need to be in a certain location. I would need to be in a hospital, a critical access hospital, a skilled nursing home, one of the approved locations to actually provide the services, which is a limiting factor. So continuing through December of 2024, audio only telehealth visits will continue to be reimbursable. So again, you can have consultations via telephone. It doesn't need to be interactive audio visual to receive reimbursement through, again, 2024. They decided to continue and extend the list of telehealth providers that are going to be eligible to provide the services. So pre-COVID, it was limited to certain practitioners, again, including, physicians and nurse practitioners. During the pandemic, they extended this to include physical therapists, occupational therapists, speech language pathologists, and audiologists. So those providers will continue to be able to provide telemedicine services through 24 and receive reimbursement for those services. Also extended the acute hospital at home program can continue to be utilized to provide hospital services to patients in their homes, and those services can continue to be provided through use of telemedicine technologies. The payment parity has been, it will continue until the end of the public health emergency. So, as mentioned, during the public health emergency, Medicare was paying for services at the same rate as they would had the service actually been provided in person, the same rate as the regular in-person visits. Now, these higher reimbursement rates are going to end. They, again, unless something is put in place to extend this or to make it permanent. So because the rates are going to be lowered, there is some thought that this will be a deterrent for providers to continue to provide services via telemedicine. And so the thought is, if that deterrent, which we do believe is there, perhaps this will cause legislature, like lawmakers and members of the legislature, to look to continue to pressure CMS, other agencies to extend this policy. It could also cause, in terms of there's various, payment parity laws in individual states for commercial payers. It may, cause lawmakers to enact legislation to require extension of payment parity at the commercial payer level as well. So some continued temporary Medicare changes that are going to be extended through 2024. Telehealth can continue to be used to conduct recertification of eligibility for hospice care. Patients with high deductible health plans that are coupled with health savings accounts are going to be permitted to use first dollar coverage for telehealth services without first having to meet their minimum deductible. We've actually seen, and there was data that showed that taking away this requirement to meet the minimum deductible actually caused for a greater increase in use of the services via telehealth. Continued also through December of 24, FQHCs and rural health clinics can continue to provide telehealth services to Medicare beneficiaries rather than being limited to being an originating site rather than being limited to being an originating site provider for telehealth, i.e. where the beneficiary is located. And then finally, for this list, the CAA also delayed the implementation of the imposition of the requisite in-person requirement for mental health services until after December of 2024. So following the end of the PHE in May, we do have this limited extension and with the hope that telemedicine will be a continued benefit till the end of December 2024. Now, Medicare covered providers can continue also to use certain apps and communications during this period, during the public health emergency, even if that app isn't in compliance with HIPAA. And I'm going to switch to and focus on HIPAA in just a minute here. The one key thing I want to actually really emphasize is the Appropriations Act and the continuations of certain of the flexibilities until December 2024 does not apply to the HIPAA waivers that are coming up. The HIPAA waivers will be in place up until the end of the PHE in May, unless and until the government takes some further actions. So, and I'll touch upon the HIPAA in just a minute here. There are some permanent changes with respect to Medicare that will remain in place post PHE and even right now post the December 2024 extension. Those changes, again, as I mentioned earlier, their focus really is on behavioral health and mental health and what services are provided by telemedicine to assist in those specialties. So permanent changes include that FQHCs and rural healthcare centers are able to serve as a distance site provider for the provision of behavioral health and mental health telemedicine services. So again, pre-COVID, FQHCs were not considered to be a distance site provider that could be used for these services and receive reimbursement from Medicare. On the flip side of this, just as FQHCs can now be a distance site provider, a permanent change is that Medicare patients are able to receive healthcare services for behavioral health, mental health using telemedicine and be in their home. They actually don't need to actually be in an FQHC or an RHC or even any other what I call sanctioned distance sites, such as hospitals, to receive these benefits, to receive care through telemedicine, and the providers are still going to be able to receive reimbursement from Medicare. So that's really important. There's no geographical restrictions for the originating site for behavioral mental health telehealth services. Really, you're seeing, and then the modality for the way that behavioral and mental health services can be provided. You can continue to use audio-only communication platforms. We think that it's significant that the permanent Medicare changes, really is focusing on these behavioral and mental telehealth services. It's probably a direct relation of, the opioid crisis and what we're seeing in the population. But it's very positive that these are permanent changes that are going to remain in place even post-epidemic, post-pandemic. And then finally, rural hospital emergency departments are now going to be accepted permanently as an originating site. So HIPAA, as you know, during the epidemic, the OIG issued a policy statement notifying providers that they won't be subject to sanctions. They won't be subject to administrative sanctions under the AKS or under the CMP, under the civil monetary penalties or exclusion laws. So in other words, they won't be subject to exclusion from participation in Medicare, Medicaid, and other programs for reducing or waiving cost sharing amounts, for services like telehealth services or remote patient monitoring services furnished to Medicare beneficiaries. Because of this policy statement, we have seen, many providers engage in this activity, waive the cost sharing, requirements as a way to make sure that patients are, able to receive these services. It was a positive thing. Now, that waiver is tied to the duration of the PHE. So that, is going away. We have not seen the OIG yet issue additional guidance saying that there will be extension after the May, ending of the PHE. So commencing May 12th, providers need to take care to make sure that they are not reducing or waiving any of these cost sharing obligations. Again, unless and until we actually see further clarification or guidance issued by the OIG. So again, you're going to need to act swiftly to make sure that your processes change and that you have new policies in place to ensure that those amounts are charged and collected. And we strongly recommend that you provide your patients as much advance notice as you can regarding this so that they are not surprised by that. So RPM services, outside of the PHE, RPM services are limited to established patients. So patients that are, where you already have an established physician-patient relationship. During the PHE and for the duration, CMS waived that established patient requirement and allowed practitioners to bill RPM for new patients. Post PHE, that's going to go away. You can only bill RPM services for services that are provided to established patients. So again, you need to make sure that you're putting policies in place to make sure that you're not providing any RPM services post-epidemic for patients who you don't already have an established physician-patient relationship with. And this suggests that you have to have had a new patient evaluation and provided management services, before rendering any RPM. So in terms of direct supervision, and I'm going to speed up here a little bit because I definitely want to get to the controlled substances and HIPAA. During the direct supervision, or excuse me, during the PHE.
Are you still talking to me while I'm trying to listen?
Thank you. So during the PHE, CMS waived the direct supervision rules to allow the supervising professional to be remote and use real-time interactive audio-visual technology. The change did not require the professional's real-time presence at or live observation of service via interactive audio-visual. Now, in the 2023 fee schedule, CMS declined to extend that temporary policy. So when in May the PHE ends, the virtual direct supervision waiver is going to also expire. Now, during during the PHE with respect to HIPAA, due to the increased use of telemedicine and the desire to make sure that providers are able to provide care for the patient, the DHHS Office of Civil Rights, the OCR, essentially announced that it was going to exercise enforcement discretion. And in doing so, they were going to allow providers to use telehealth in good faith, even if the platform did not follow or meet the HIPAA rules. Now, there are a number of providers that we've seen because of presumably because of the pandemic, and providers of these digital health platforms and technologies, confirm and ensure that their platforms are indeed now HIPAA compliant. And this is important because after May 11th, the OCR is going to resume enforcement of penalties on providers that are using non-compliant HIPAA platforms, that are using technology that are not compliant with the HIPAA rules. So one of the things you're going to want to make sure is if you have a license agreement, any of your agreements for these technologies, you're going to want to make sure as a provider that you have representations and warranties that those technologies, the platforms, are compliant with HIPAA. Where needed, you're going to want to have a business associate agreement in place. And if you're a vendor of these technologies, you're going to want to do what you can to make sure that your policies, or excuse me, that your platforms, your technologies are HIPAA compliant. Many of the platforms that we're seeing being used, Teams, for example, are HIPAA compliant. Now, ahead of the end of the PHE, the OCR did provide guidance and clarification on how the HIPAA rules will apply to telehealth. And I strongly recommend everybody read the OCR HIPAA guidance. It provides some very helpful examples, questions and answers. And these are a few, some snapshots from that guidance document. Now, the OCR has said that you can continue to use remote communication technologies to provide audio-only telehealth services when such communications are conducted in a manner that is compliant with HIPAA. So one of the questions and answers, does the HIPAA privacy rule permit providers to use remote communications to provide audio-only services? And the answer is yes. Now, do the healthcare providers have to meet the requirements of the security rule? Now, remember, HIPAA has a security rule and the privacy rule. in order to use these remote communication technologies to provide audio-only telehealth services. Now here the guidance says yes, but only in certain circumstances. So what you need to consider is that the HIPAA security rule doesn't apply to audio-only telehealth, provided when a provider is using a standard telephone line. So consider a landline. But, and that's probably few and far between, because I don't know many people these days who just are using landlines, but I could be wrong. But the security rule would apply when a physician, when a provider is using mobile technologies, electronic communication technologies that use the internet, Wi-Fi, cellular. Again, so if you're communicating with the patient and you're using Wi-Fi, cellular telephones, the internet, that is a communication that is going to require compliance with the security rule. It's rare that this would not be applicable. Now, it is important to remember that the individual that's receiving the telehealth services, we can use any type of communication we want. So this really applies to the provider and what type of media, what type of technology you're using to provide the services. I am not governed by, the security rule. So, a covered entity is not responsible. The provider is not responsible for the privacy or security of my information once it's been received by me on my phone or my device. Here's another example. Does the HIPAA rule permit a provider to conduct audio only using remote communication technologies when you don't have a BAA in place with the vendor? Again, as I mentioned, there's a lot of vendors of these technologies now that are entering into business associate agreements. They have their standard ones and they are HIPAA compliant. But for those that don't, you are allowed to enter into an agreement with that vendor if the vendor is really only a conduit of the information. So if the PHI, if the vendor is only used to transient, if the vendor only has transient access to the PHI, it transmits because it's merely acting as a conduit, then you don't need a BAA in place. However, if the vendor is more than just a conduit for the PHI, you would need a BAA in place. So again, I recommend that you pull up and look at the OCR HIPAA guidance because it provides some good examples of what the OIG is going to be doing post pandemic in terms of looking at HIPAA enforcement and compliance. So prescribing, of course, you have various state laws and federal laws addressing the use of telemedicine technology to provide a prescription. So you have to look at the state laws again in terms of when do you establish a physician-patient relationship, what type of modality can you use, and then are you able to write that prescription? Is it for a controlled substance or a non-controlled substance? So some states require that you actually have an in-person physical exam prior to issuing any prescription. Some states allow for a first in-person exam to be conducted, using telemedicine, and other states are silent. And then you have federal laws addressing controlled substances, specifically, the Ryan Haight Online Pharmacy Consumer Protection Act. Now, in California, you do have internet prescribing law, and what your law requires is that you have to have an in-person examination prior to prior to issuing a prescription. However, according to your professions and your business and professions code, an appropriate prior examination doesn't require a synchronous interaction between the patient and the licensee, and it can be achieved through the use of telehealth, including, but not limited to a screening tool or questionnaire. Again, provided you comply with the appropriate level of standard of care. Now that's for non-controlled substances. Controlled substances, again, are governed by the Ryan-Haight Act. And it's a federal prohibition on online prescribing of controlled substances. It's a per se violation of the CSA to prescribe a controlled substance absent at least one in-person medical exam, except in specific circumstances. Now the limitations, and again, I'm going quickly, so I apologize, but the exceptions to this are, if the patient's in a hospital or clinic, there's a special registration exception, which we're still waiting for. And then there's an other circumstances specified by regulation exception. And that's the exception that was used during the PHE, or excuse me, there's a public health emergency exception that obviously was used during the PHE. The other circumstances specified by regulation exception is what is proposed in the DEA by the DA in the proposed rules as a potential extension of the waivers. So during the PHE, the DEA revised the remote prescribing restriction so that a prescription could be issued for a controlled substance without an initial in-person exam if certain conditions were met. And these are the conditions that had to be met for that examination for that controlled substance to be prescribed absent an in-person examination. So it had to be issued for a legitimate medical purpose by a practitioner acting in the usual course of practice. The telemedicine communication is conducted. It could be used by audiovisual, real-time, and two-way interactive. And the practitioner is acting in accordance with applicable laws. So those were that was the relaxation during the public health emergency. Now, the special registration for Telemedicine Clarification Act, really addresses that special registration exception I mentioned in the beginning. And what that would do is it would allow practitioners to use telemedicine only to prescribe controlled substances, without a per se in-person exam. That registration has not been addressed yet. And in February last month, the DEA announced proposed rules, which everybody was very excited for prescribing controlled substances via telemedicine after the PHE expires. And the hope was that these proposed rules would address not only the special registration exception, but would also closely mirror the waivers that were put in place during the public health emergency. Now, these are proposed rules, and there's a 30-day comment period for them. So again, proposed. What the DEA did in their proposed rules is they created two new options for telemedicine's prescribing of a controlled substance without an in-person exam. Unfortunately, they're very, very limited options, and they were not as broad as we were hoping that they would be. The options are created, the proposed options are created under, as I mentioned, exception 7 under the Ryan-Haight Act, that other circumstances specified by regulation exception. So the rules designed to ensure that patients don't experience lapses in care. However, again, they're limited. So the two options are this. Option 1 is a virtual first process where a physician could issue an initial prescription for a controlled substance without having an in-person exam, but only if these two conditions are met. The medication is not a non-narcotic Schedule 3, 4, or 5 controlled substance, and this prescribed amount does not exceed 30 days. It's called a telemedicine prescription. Before an additional prescribing can occur, however, the patient must undergo an in-person exam. And then option 2, which is a qualified telemedicine referral process, the patient has an initial in-person exam with a physician who subsequently refers the patient to a second practitioner. That second practitioner can then have a telemedicine exam on the patient and prescribe a controlled substance without personally conducting an in-person exam of the patient. So real quickly, those are the two proposed options that the DEA has put out for in their proposed rules for how to prescribe a controlled substance without an in-person exam using telemedicine post PEA. So again, they're expanded options, but they're more restrictive and limiting than what is currently available under the pandemic. I'm going to kind of fly through these. It doesn't apply to all telemedicine prescribing. Again, it's much more limiting. The DEA, essentially says that this, is not proposed to affect, what they refer to as a narrow subset of telemedicine consultations, but it would apply to any practitioners. They do have a proposed definition of a telemedicine prescription, and it's any prescription issued pursuant to section 1306.31 by a physician. And forgive me, I'm scrolling through because we only have a few more minutes, and I want to touch really quickly on fraud and abuse. So again, I'm flying through that DEA rule is a proposed rule. You can, we've actually issued a lot of documentation and alerts on it. As commentary is received on that proposed rule, we will provide you with additional information. We're going to continue to monitor it, and including if any changes are made to the proposal. So fraud and abuse in telemedicine is a big focus right now of the Office of Inspector General and the Department of Justice. The Office of Inspector General published a special fraud alert, which really, in my mind, it's a great roadmap because it gives practitioners and telemedicine companies a roadmap for what not to do. It can be used to show how you really can build, develop, and deliver a compliant telehealth program. And the OIG set forth and identified 7 characteristics that they believe would cause a potential arrangement to be fraught with fraud and abuse considerations. So again, it's not intended to be a deterrent, but I really think that it is something that practitioners and telehealth companies should really use as a roadmap for how to structure a compliant program. And really, the OIG issued this because there's been so much exploitation of the use of telemedicine. There's been so much growth of the use of telemedicine. So they outlined, again, the 7 characteristics of what, and again, please, one, you don't have to meet all 7 for something to be fraught with fraud and abuse issues. Any one or more of these could lead to the OIG or the Department of Justice thinking that a telemedicine offering is in violation of the fraud and abuse laws. So these may seem pretty apparent to you, but I really suggest everybody look at the special fraud alert. So the 7 characteristics include the patients from whom the physician would order or prescribe items were identified or recruited by like a marketing company or a sales agent or through advertising for free or low cost items. The physician doesn't have really sufficient contact with the patient or any information from the patient to actually perform a medical assessment and then prescribe. And I'll show you some examples of ones that came up here. The telemedicine company actually compensates the physician based on the volume of items that they prescribe or the items that they refer. And the compensation is based on the number of medical records or, for example, the number of records that they've reviewed. The company only furnishes items to or services to beneficiaries of a federal healthcare program and doesn't accept insurance from other payers. They only claim to accept, to furnish items to Medicare beneficiaries, but then they might in fact bill other programs as well. They furnish only one class of product or services, thereby restricting the ability of a practitioner to determine what they think is in the best interest of their patient. And then they don't expect the practitioner to actually follow up with the patient, nor does it actually provide the practitioner with the ability to follow up with the patient. So again, these are characteristics that the OIG thinks would lead the OIG to suspect that a telemedicine offering is not compliant. Because of this, and because of this influx of the use of telemedicine, these programs, we are seeing, and we think we're going to continue to see, an increase in the DOJ and the Department of Health and Human Services, OIG, to investigate telemedicine companies and the provision of care via telemedicine, and is actually part of their compliance program. So enforcement's going to probably be in the form of like search warrants, subpoenas, civil investigative demands, false claims acts demands. There's definitely a focus on data mining, and we see that is thriving. And the OIG and the DOJ has indicated they're going to also look at these data mining companies where they're actually gaining information from these telemedicine companies. So there's been a number of fraud trends. This is an example of a scheme that was deemed to be in violation of the fraud and abuse laws, where essentially there were call centers that initiated patient contacts regardless of whether the physician determined any medical necessity. The physician was sent patient information, they would just write a prescription, for example. Again, it seems pretty straightforward, but things to consider when you're engaging in. If you're a physician and you're approached by an entity to engage in one of these activities, really sit back and consider, are you able to provide the care for the patient? Do you have sufficient interactions with the patient? Can you determine what's medically necessary? How are you being compensated? And then finally, if you're going to start engaging in the provision of clinical research or clinical trials using telemedicine technologies, you need to be aware that in addition to all of the general regulations that you would need to comply with to perform clinical research, you are also going to be now required to comply with all of the state statutes and regulations for the provision of care via telemedicine. There's a number of states where the practice of medicine includes the provision of clinical research, engaging in that. So when you're engaging in a clinical trial, if you're forming one, if you're forming an investigator-initiated trial, if you're approached by a pharmaceutical company or medical device company to engage in research and involves telemedicine, if you're a pharmaceutical company or medical device company going to design clinical research that involves care or procedures using these telemedicine technologies, you need to remember and consider that all of the state regulations regarding licensure, practice standards, modalities, additional requirements regarding informed consent also apply. So again, I am so sorry that was a quick run through. I wanted to cover a lot in a very short time. So I would be happy post this to receive and answer any questions. My contact information obviously is here. So I appreciate everybody participating, your time, and thank you for having me here. And apologies for going over.
No worries. We do have quite a few questions. I'm curious if you will be able to stay on for a few minutes to answer a few.
I was trying. I can for a minute or two here. Yes, it's the best way for me to open the chat.
Okay, we'll take a few questions. I want to let everybody know as part of our follow-up, when we do send out the email that will contain these slides and presentation materials, we will also be sure to include a summary of the Q&A. So we will get an answer to the questions that we don't have time for in the live session, and we will get those sent to you via email within a week. Okay, so thank you all so much. Let's see what questions. We have quite a few. I'll start with one from Marla asking, after May 11th, when the COVID-19 mandate ends, will payers continue to allow, I think we covered that in this session. Let's see. When does Medicare payment parity end?
So payment parity is ending in May for Medicare.
With that PHE date.
So for the PHE, and I'm scrolling through these as well.
When it comes to licensing and location requirements, can a rural health provider working for a California organization with a California license provide telehealth services if they reside in another state, but the patient is in California?
Okay, so hold on, let me just read that one again. So kind of working for a California organization, California licensed telehealth if they reside in another state and provide patients. So yes, because well, okay, so let me take a step back. For Medicare reimbursement, yes, Medicare has actually said that they've extended and they've made it permanent that they will allow for reimbursement for that provider to provide services for a patient in California and not necessarily be licensed in the state of California. However, that's the regulation for Medicare reimbursement. You still have the California licensure requirements. So under California statute, and I'll go back and confirm this, but to my knowledge, California did not extend the waiver for this. So in order, I'm correct in that, they didn't extend the waiver. So the physician would actually need to be licensed in California if they are providing services for the California patient. So it gets confusing because there's an overlap. You have the Medicare requirements for reimbursement for those services, and they also have licensure requirements. But then, and those are ones that were waived, and then there's some permanent waivers for rural healthcare, some of the behavioral healthcare post PHE, but those are separate and distinct from the individual state licensure requirements, which have not; those waivers have now.
Here's one gotten a few times. For HIPAA compliance, does it have to be established as HIPAA compliant, or does a BAA also have to be in place?
So it depends is the answer. And I know that's never a good answer. So the platform should, if they are going to be doing, or if the service provider is going to be more than a conduit of the information, of the communication, you need to have, the platform needs to be HIPAA compliant. If they're going to be more than a conduit and they're providing services or functions that fall within what are considered to be the services that require a business associate agreement, then it needs to be both HIPAA compliant and they need to actually execute a business associate agreement. The vast majority of the times, they're one and the same, and you will need this associate agreement in addition to the platform being HIPAA compliant. There was one very skew example of when you didn't need a business associate agreement, but I'm not even going to go into it because it's really not relevant. I think the best practice is to assume and require that you have a HIPAA compliant, a rep and warranty for a HIPAA compliant platform, coupled with a business associate agreement that entity is signing.
Great. And I know we talked about Medicare. Are there any additional things we want to cover with commercial payers such as Blue Cross, Cigna, UHC? Any differences there?
So it's all the payers is going to be very obviously state specific, right? So each of the payers can determine, what they will provide reimbursement for. Are they going to, if they had increased reimbursement or coverage for services provided telehealth during the pandemic, are they going to continue to extend those? Now, where the payers are governed by individual state payment or coverage parity laws, they will have to follow those parity laws. So, during the PHE, there were certain states that had requirements and extended their payment parity laws and payment coverage laws, which require the commercial payers to provide greater payment parity or greater coverage parity. Again, it's pre or post, post PHE, to the extent there were any of those requirements, it's simply going to be dependent upon what the state law says. Are the state payment parity laws still in place? Have they been extended? Have they been expanded upon? So any of the Blues, Aetna, United, they are going to be governed by applicable state payment parity laws and state coverage, coverage parity laws to the extent there are any.
Great. There's a question asking for a little bit of clarification. Earlier in the webinar, they believe they heard that payment parity was extended to 2024, but in the Q&A it was noted as May, so they just want to clarify for California an extension.
So forgive me if there was a bit of ambiguity there. So for California, I need to go back and confirm. I don't believe there is payment parity extension in California for any of the commercial payers. Again, but I will confirm that, and I can send follow-up information in the chat.
Sorry, real quick. I just got a message that they were referring to federal, not state, and they accidentally didn't clarify that.
Yes. Okay. So sorry. Thank you for that clarification. No. So Medicare did not extend the payment parity post May. Now, where they had some changes, and let me see if I just want to clarify something in terms of, because I don't want to misspeak. I think there, as I'm going through this so fast, there was some payment parity extended, but it was only for behavioral and mental health service provision through. It was, so no, they did not extend that beyond the PHE. So sorry for the confusion there.
No, thank you for the
In
clarification.
between federal and state and all different PHE, it gets a little bit blurred, so apologies for that.
I also have a few questions when it comes to prescribing. I want to clarify if someone has established a patient through the PHE over telehealth, and looks like they're wondering, after the 151-day allowance for established patients, do we have to see them in person since we have been prescribing Control 2, or can they then get a referral from their PCP and come back to continue treatment? It is a proposed rule, so yeah. So as we're still trying to parse this out and analyze it, to be quite honest, because it does seem like a bit of a gray area, but we can provide you again with more information as this comes out, because that was one of the things that, so Foley, we're actually developing, and we've been working with the DEA, because the DEA actually reached out to us directly to ask us, with some comments about the proposed rules. And that was actually one of the questions that we actually had, because we were looking for some clarification on that. There isn't any quote unquote at this point, again, they're proposed, but there isn't any quote unquote grandfathering at this point for patients that were seen during, as we understand it. And again, we've asked for clarification on it, so please take this with a grain of salt. But we understand that there isn't any quote unquote grandfathering for patients who were initially seen during the PHE, post PHE. So if you're going to, so I understand what we interpret the proposed rule as saying, that if you're going to then,
issue a prescription, if you're intending to offer a new controlled substance prescription for a patient, post that 151 days, it would then require a new in-person exam. That's the way right now we're interpreting that proposed rule. But again, we've reached out for this.
Great.
Oh, and then I think I probably have time for about one more, and then I do apologize because I do have another meeting that I need to get on actually about the proposed rule. So
Appreciate it. Yeah, we'll take one more question. Thank you for staying on.
and I apologize, I was so long-winded and ran over, so I'm happy to do so.
A lot of good information. Let's see, one more question. If a provider works both in a clinic and on occasion does virtual visits from their home, do they have to enroll their home address as a site of service?
So they're not going to be able to continue to do this at their home post PHE, unless it's considered to be, they're not going to be able to do it post PHE. So that's something that we're advising providers. Now again, there's some exceptions for behavioral health services, things like that we can provide you with some information on. But what we are telling providers is that they need to essentially make sure that they're in the proper locations to provide these services post PHE. So it becomes a bit moot, if you will.
For sure. And then just real quick last, do you suggest they submit comments to the DEA individually or collectively?
Collectively.
For sure.
Because it provides more leverage and more weight with that. And we're happy to help facilitate that. I'm sure the CTRC can help facilitate that as well, but there's a weight in numbers, if you will.
Definitely. All right, well, I think that's all the time we have for questions live. Again, we will send these out via email and follow-up materials. Just want to quickly let you guys know of some upcoming events from CTRC. Our next webinar is going to be on the national consortium side. So please register and join us for social determinants of health and value-based pay on April 20th. That's going to be our next webinar. We also want to let you know that our summit is happening this year in June, and we're really excited for it. Registration is going to be opening later this week, so we hope to see you all there virtually in attendance. We want to see some familiar faces at our summit, and that's what's happening next from CTRC. Thank you, everyone, for being here today. We hope to see you again soon, and much appreciation for Monica for a lot of great information and helpful content shared today. It was really informative, educational. So thank you so much for being here and sharing your expertise.
Thank you, everyone.